Thank you very much. We're going to reconvene. This session is intended to give additional background and context for the committee for the study. Thomas and Rebecca are here. Helene will be coming in later. And then we will also have Bot, who is from Medtronics, who will call in probably around 4:45 or so. And so I think we will start with Thomas, and thank you very much for both of you being here and contributing to supporting the committee in terms of giving us a little bit of a better understanding. I don't know if you were here earlier in the earlier session, we especially when we're looking at 3 questions, the internal versus external focus, looking at how do we get the efficiencies and coordination, and then also looking at the broader context of the global health agenda, essentially. But we welcome your comments, your expertise, and sharing your experience with the committee. So we'll start with you, Thomas.
Well, thank you so much.
Introduce yourself as well.
My name is Tom Bollyky. I'm a senior fellow for global health, economics, and development at the Council on Foreign Relations. Council on Foreign Relations, for those of you that don't know, is a think tank and a membership institution based here in DC, but also in New York. I'm pleased to be here. I am sitting on a different National Academy of Medicine's Committee or Sciences Committee on the future of USAID. So I have great appreciation for the work that you're doing here, and we're nearing the end and you all are just starting out, so I don't envy you, but I think it'll be an interesting and lively process. So I was asked to present a set of remarks about the charge that the committee was given, but also particularly emphasize non-communicable diseases. I'm going to try to do that. I'm going to do that by walking through very briefly what I see as the changing global health landscape, focus particularly on non-communicable diseases as an element of that changing global health landscape, and then move on to a few recommendations on how we might improve the efficiency and responsiveness of U.S. global health, particularly to NCDs, but also to perhaps a little more broadly. We did bring reports that were part of the Council's Task Force on Non-Communicable Diseases, and those are floating around here somewhere, but I think you, whoever wants them, can certainly have a copy. We don't want to bring them back, so you need to take them. All right, so the President, for those of you that missed it, in the United Nations gave a lovely final speech before the General Assembly in which he emphasized what he saw as the defining paradox in the world today, which is that we've made enormous progress in improving the prosperity of the world and reducing conflict, but at the same time there's a rising lack of trust or a lack of support for the institutions and the investments that have given rise to that prosperity and that peace. I think there's a partial analogy here to global health, in that really what this committee is charged with is thinking about how to manage partial progress in global health, or partial success. And we've seen enormous amount of progress, particularly in the last 15 years, but also a flatlining of budgets and some diminishment perhaps of the energy around global health. And how do you maintain the programs and investment that have driven success, and there's still more to be done, while still remaining relevant to the emerging concerns that are happening in global health? And that's what I'm going to talk about today. So first is that obviously there's been tremendous progress in global health. This is just a slide showing the last, since 1990, moving forward on maternal, newborn, and child health. The progress there has been spectacular. Maternal mortality in the last 15 years has dropped 43%. Deaths under 5 have halved globally. 19,000 fewer children die each day. You see similar progress in other areas, 48% reductions in global deaths from malaria, 47 from TB. In 2003, there were 100,000 people on antiretroviral treatment. In sub-Saharan Africa, now there are 10 million. There's certainly much more to be done, but great progress to be seen. This has come in large part because of Sorry about that. Should I wait? No, that's okay. I don't. This has come in large part because of U.S. investments. The U.S. investment in the PEPFAR program is the single largest financial investment of any country to global health and to the treatment of one disease. The U.S. is the largest donor of Gavi in the Global Fund. It also provides most aid for neglected tropical diseases, maternal, child, and health, malaria, and TB. All these areas the U.S. leads. These investments have been bipartisan and cost-effective, coming at 0.3% of U.S. spending in 2015. That's a great return on investment. But you are starting to see these investments flatline in recent years. The same is true globally. We're really, since 2010, we haven't seen the same level of increases in global health spending as we've seen before. The United States and other donors have rallied generously to invest in longstanding commitments, like recently the Global Fund replenishment. But even in these areas, the gap between the likely availability of resources and where these programs need to go are substantial. The estimate is the Global Fund needs $20 billion in the next 3 years. It's not clear where those resources are going to come from. The slow and anemic response to the Zika virus outbreak in the US was also occurring globally. It's not that others are doing significantly better in freeing up resources for Zika, and that suggests a lack of potential interest in emerging global challenges. There's also a chance that global health investment is poised to decline. Really, the drive over the last 5 years has been driven by three entities maintaining their investment, the United Kingdom, the United States, and the Gates Foundation. And obviously after Brexit, it's hard to know what will happen in the United Kingdom in terms of that continued support. At the same time, we have emerging challenges. I put them in quotes as emerging is because they're not new at all. These have been coming for a long time, all of them. But they haven't been the traditional focus of our global health investments, not just in the US, but abroad as well. I'm not going to speak about emerging infectious diseases because I know my colleague here is going to, but that's clearly one. The world has changed in ways that are conducive to the spread of emerging infectious disease. Overuse of antibiotics in agriculture and medical practice and underinvestment in new antibiotics clearly have led to antibiotic resistance or antimicrobial resistance, and you have, of course, NCDs, where I'm going to spend my time. What you hear a lot in global health circles is this is all okay because this will lead to a transition on the country level, blended financing. And depending on who you talk, or depending on the evidence you use, this was a Lancet study looking at 1990 to 2013 levels of spending in national health per capita, but projecting it out to 2040. I don't want to pretend these projections to 2040 are accurate, but they give you a sense of what the current level of spending is, which is per capita in sub-Saharan Africa, you are looking at 3 cents spent on health for every dollar spent in high-income countries. And that shifting to domestic entities is going to be a significant challenge in that regard. So let's focus on NCDs because that's why you've invited me here to speak. We recently had our first task force devoted to health at the council. It's about time. We're about a 100-year-old institution, but I was pleased that it was focused on NCDs. It was really led by a fantastic set of committee members. Tom Donlin was one of the chairs. Mitch Daniels was the other chairs. We really had, even by CFR standards, a all-star cast, and I urge you to look at the report. And the way we had attracted these people who had, by and large, not spoken on NCDs is we asked them 3 questions, and we told them they could genuinely say no. And the first question was, are NCDs an emerging crisis in low and middle-income countries? The second, does the US and other donors have an interest in addressing that crisis? And the last is, why now? Shouldn't we finish the infectious disease agenda? Shouldn't we finish the agenda on maternal and newborn and child health? So, is it a crisis? First, it needs to be said that the distribution of NCDs or the burden of NCDs in low and middle income countries looks different than it does here. It is more dominated by cardiovascular diseases. Cancers come as the second largest part of the burden. Chronic respiratory illnesses. Diabetes is a relatively small part of the burden, but growing the fastest. So why to be concerned? And what we found is when we dug into the data, and most of this data, but by no means all, comes from the Global Burden of Disease Project, and I should credit Chris Murray, who was on this task force. But what we found is deaths from NCDs in low and middle income countries increased 53% between 1990 and 2013. That is roughly twice the rate of population growth. They're now just increasing faster. They're increasing in much younger populations. The burden that is arising, we took a stricter standard of prematurity than the WHO does, which is under 70. We looked at 59 and younger. And 80% or more of that burden in sub-Saharan Africa or in South Asia from NCDs occurs in populations 59 and younger, so really young. It is also having dramatically worse outcomes. This is particularly true on cardiovascular disease, but you see similar trends on diabetes and chronic respiratory illnesses as well. On cancers, it really breaks down by the cancer. Some of them are roughly similar, and some of them have dramatic differences with high-income countries. So isn't this a byproduct of success? Isn't this a sign of progress? Isn't it better that these people are no longer dying at a very young age from malaria? They are now have the gift of dying at a slightly older age from cardiovascular disease. And what we found is that it isn't. The rates of increase on NCDs, particularly in low-income countries, is 3 times higher than the rate of decline of NCDs. Of communicable diseases. It is a third faster in lower middle income countries. A lot of the unhealthy lifestyles that we might associate with non-communicable diseases in high income countries, still relatively low in low and middle income countries. The rate of adult obesity in a low income country is 5%. The rate of your average low income country, the rate of adult obesity in a lower middle income country is 7%. In the US, it's 35%. So substantial differences, and if you look at physical inactivity, you see a similar pattern. It is also not associated with higher incomes, at least not premature mortality is. This is from a study we did in Health Affairs. You see a statistically significant tie between poverty of a country and the rate of premature mortality for most NCDs. That rate of connection between poverty and NCDs is actually greater than it is for HIV. It's greater than it is for dengue. It's greater than it is for upper respiratory illnesses. So what is driving it? Well, what's driving it is the same thing that's driving other global health problems: poverty and limited health systems. Countries are transitioning epidemiologically. Fewer children are dying, which is wonderful news. But that has not been accompanied by the same gains in wealth that you saw in higher income countries that made that transition. What do I mean by that? When OECD countries hit a median life expectancy of 59, which happened way back in 1946, the GDP per capita was $4,300. In lower middle income countries, $2,200 back in 1986. Low income countries just passed that threshold. The GDP per capita is 1,000. As I mentioned, health spending is on the rise in low and middle income countries. That's good news, but it's still really low. All countries of sub-Saharan Africa combined, their governments spend about as much on healthcare as the government of Poland. If you look at all governments of low and middle income countries, they spend about as much on healthcare as the governments of France, Canada, Germany, and the UK combined. The difference, of course, on one hand is you have 5.7 billion people, on the other hand, you have about 300 million people. So substantial differences. You, of course, also have unprecedented rates of urbanization in low and middle income countries, particularly in South Asia and sub-Saharan Africa, and you do see some increases of health risks, particularly tobacco. So what does this mean? What it boils down to is countries where have limited preventative care, so people tend to, and some increase in risk, so they tend to get NCDs younger. And because they have limited chronic care and limited ability to pay out of pocket, they tend to die earlier. And that's really what is driving the NCD epidemic in low and middle income countries. So that looks bad. Why should the US care? Well, I should say currently the US doesn't, not at least in terms of financial resources. There are no dedicated programs or budgets directed purely to NCDs. There are some small scale ad hoc efforts. This may be changing more recently, but pretty small scale. When we looked at it, we really dug through all the budgets of all the agencies. The most generous allocation we could give was $10.8 million spent in 2013. That works out to 0.12% of global health spending. This is, of course, for a set of diseases that premature represent a greater burden in low and middle income countries than communicable diseases. Other bilateral donor investments on NCDs are broadly similar. Overall, you're looking at about 1.3% of global health aid. So isn't this understandable? Because ultimately NCDs aren't a direct health risk to the US. Shouldn't we emphasize our investments there? And as obviously this committee knows, but maybe not everybody in the audience, is that the reality is relatively little of our budget goes to direct health threats to the United States. It goes to endemic infectious disease or other conditions such as poor maternal child health, malaria, even HIV, family planning, reproductive health, that the burden of these challenges in low middle income countries, let's say Malawi, has absolutely nothing to do with the burden of these challenges in Indiana. So why do we invest in them? We invest in them because we care about these countries and their populations. So what did we do? We looked at the 49 countries that receive $5 million more annually in global health aid, and we looked at what the burden is. And what you find is the rate of DALYs from NCDs is 6 times higher in the same 49 countries as HIV, 6 times. The rate of DALYs from NCDs is almost twice as high as malaria, TB, and HIV combined in the same countries as we invest in. I urge you all not just to look at our fancy report, but we have an online interactive that has each of these 49 countries' case studies, and you can look at what U.S. global health aid has been in overall and what it has been for NCDs. You can see the pattern, and we really dug down: rate of urbanization, percentage that's adult population, lots of information. Please check it out. So it's also these diseases are starting to manifest themselves in pretty early ages. As I mentioned, late 30s is really when you're seeing it. That's not very different from other global health concerns. People forget how old people are that are affected by other diseases. The average age of death from HIV globally is 38. The average age of death globally from TB is 54. So we are really talking about similar age ranges as the people we address now. And you can look at different estimates of the economic impact. I will throw out this one, which the World Economic Forum did, David Bloom did it, which was just for low and middle income countries, an economic cost of $21 trillion between the date of that report and 2030. So substantial economic impact. So why now? And here I'll put out a couple of arguments. The first is that because this is rising at such a scale, such a large number of people, 8 million people died before the age of 59 just in low and middle income countries from NCDs. It has an impact through the health system. This matters to the US because we are, of course, interested in transitioning our global health investments. And if people are presenting late and occupying health facilities and the cost, that makes it more difficult. Countries shift their resources to that, and that makes it more difficult to assume the burden of the global health programs we'd like them to assume. There's also the matter of the potential. If you just look at what the projected with population and demographic change, what the projected rate of premature deaths are just in those 49 countries the US is invested in now, and what it would be if they had the rate of the average high-income country from premature deaths. And what you find is that's a difference of 12 million lives. That's a spectacular opportunity in terms of investment, but when you speak to people like we had Eric Gooseby on this panel, you have people showing up at PEPFAR clinics, clearly hypertensive, and we have people with one set of preventable treatable diseases perishing because we are investing in another set of preventable and treatable diseases, and that just seems like poor financial stewardship. All right, potential strategies for U.S. engagement. We have these in the report. I will emphasize the first set, which are things that are doable now, and with the committee argued, our task force argued rather, with existing global health infrastructure. Tobacco control works in poor countries, works in wealthy countries. Hypertension, there has been some emphasis on this. I just hosted a meeting with Tom Frieden and Mayor Bloomberg and Margaret Chan launching a new initiative on hypertension. And then there are the vaccine preventable cancers, which of course can leverage at least some of the infrastructure. I recognize that they're geared towards a different age group, but they can leverage some of the infrastructure. Again, the same health affairs studies, we looked at countries that had actually made a significant improvement in NCDs. And this is something to emphasize, is what drove that improvement. What you find is it's not population-based prevention on most of the areas that you would think. So in many of the countries that achieve the 25% reduction that we want them to achieve, within a similar time frame as what the WHO is asking countries to do now under a 25 by 25 goal, most of them had increasing rates of obesity, binge drinking, sodium consumption, and physical inactivity. What did they do, these countries that had improvements? Well, they had GDP per capita growth, which probably we think ties to health spending and access to health care. And they had dramatic reductions in smoking. And that's really what you see as making difference. This is not just a population-based prevention story. We're asking low and middle-income countries to do what we ourselves have never been able to do. This is a treatment story, and it's a tobacco control story. All right, so what conclusions? Clearly, to put this within the committee's charge, it is important to sustain and build on existing U.S. commitments to global health. That agenda is by no means done. Nobody thinks or I don't think, it's a good idea to pit global health causes against one another. But to retain their relevance and their support, they must adapt and integrate changing circumstances and emerging concerns. To do that, we need to shift from our current very disease-focused approach to global health, which is a supply-driven approach, to more a demand-driven approach of the outcomes that we want to achieve in those populations. That means much more investment in data to allow that to happen. You also, by doing this, you have a better opportunity to integrate these programs more into U.S. diplomacy and the foreign policy agenda, which increase their domestic relevance. If they're more relevant to the countries that we're engaging in, it provides a better opportunity to sustain them. Let me pause there and let my colleagues speak.